Rhoda Kalendo from Kenyatta National Hospital. Welcome to today's session. In the Q&A section, how are you, Edward? Glad that you're set for the session. Peter Mwangi, you're asking how long will it take? The scheduled time is between 2 to 3:30 p.m., but it depends with the duration of the presentation that the presenter will make. Sometimes it might take 1 hour, sometimes it might take 1.5 hours, and we hope we'll be able to have you logged in during that time. So karibu sana. To the other participants, welcome to today's session. We are glad to have all of you, all 580 of you and more still joining. Karibu to today's session. Today is a very interesting session. We'll be talking about stigma, and we'd love to hear your experience. Kindly share your experience in the Q&A section about stigma. I know you're all working in different facilities, different centers, some directly in the clinical field or frontline, others might be in administration, but kindly share with us your experience, either whether you've gotten any stigma from your colleagues, your neighbors, where you stay, including your relatives. That includes your relatives. It will be good to hear from you and also understand what you're going through as a frontline healthcare worker. I'd like to introduce our presenter, Professor Lukoya Tweli, to start us off in this session. Professor Lukoya, karibu sana to this session.
Thank you. Thank you very much, Rhoda, for the kind introduction. I'm going to project my screen. Okay, all right. So I think when we talk about stigma, we are talking about the difficulty some people have in just being, good human beings. Sorry, I'm not sure what happened there. Okay, yeah, so I mean, when you talk about stigma, we're talking about the difficulty some human beings have just being nice to others. Because if everybody makes an effort to, not to go out of their way to be nasty to other people, no matter what their circumstances are, then we would have less to do with stigma than we're having now. But it's a human tendency that we tend to group, and when we group, we tend to make our group look good and all other groups to look less than good. And as a result, then we will give them characteristics that ensure that we distinguish them from ourselves and ensure that they always remain less than good as far as our own group is concerned. And when it is concerning something like COVID-19, then it becomes a group where we are the ones without COVID-19, the ones who are unaffected by COVID-19, and those are the groups of people who are somehow affected, then they are less than good and they are less than perfect compared to who we are. So that is really, at the end of the day, what this talk is all about. And then we ask ourselves, why are people like this? And is it normal for people to be like this? And the answer is that yes, it is normal for people to be like this because we have evolved on this earth from the time we started and survived thus far by helping each other in groups of people who are familiar with each other for one reason or another. In the past, when we didn't have language or we didn't have a better understanding of how the world looks like, it was safe and adaptive for us to label any other strange person or any person with a strange attribute as being potentially risky to us. And so we have developed that innate ability to quickly characterize people in order to classify them as being safe or unsafe, good or bad, and so on. And so stigma falls into this adaptation in that way. And I keep thinking about what drives it from the beginning. And I keep thinking that it is about how we handle grief. And I have used this slide before in talking about how to deal with COVID-related grief. But I keep thinking that how we handle this grief and how we process it and how we come out of it at an individual level determines how we handle other people with the same problem as we may have experienced or that we fear we may experience. And therefore, it is a good thing, in my view, for us to go through this again in order to frame then what happens when stigma comes along. And so I've developed this out of the stages of death and dying by Elizabeth Kubler-Ross, which were later elaborated into stages of grief, as indicated on the left, and indicated the risks that are there as far as COVID-19 is concerned for a person in each of the stages of grief that I have put on the left, and then how somebody can get help. Because I think we need help at whichever stage we are in and what the desired outcome should be. So since I've done this before, I'll go through this chart relatively quickly in order to frame the discussion going forward. I think people in the denial stage, as far as this COVID-19 is concerned, are at highest risk of infection and spread. They're at highest risk of having stigmatizing attitudes towards people who have COVID-19 or who have different attitudes towards COVID-19. They are at the highest risk of getting infected themselves because their behavior, if it is in tandem with the things they believe and is in tandem with their stage of denial, then would be more risky than somebody who is not in that stage. And if somebody is in that stage, even at this time, as the pandemic spreads across the country, then it is still important to encourage this person to get accurate information from trusted sources. And the keyword here being trusted. And we would still hope that there are certain sources of information, scientific health information, that are still trusted in this world. If you do not trust what the Ministry of Health is saying, there's the WHO. If you do not trust the WHO, find another globally recognized institution that regularly generates information that you find to be trustworthy, even if it is an academic institution, if it is a University of Nairobi, if it is, whatever, Johns Hopkins, Harvard, whatever you think is trustworthy, go there then and see what are they saying about this pandemic. If you find that they validate your views, then well and good, you will have found a trusted source of information that you can continue tracking over time. But there are many newfangled sources of information that many of us are just discovering now during this pandemic. My feeling is that if you didn't know about it before COVID-19, if it wasn't known before COVID-19 and is becoming prominent now, then the risk is that it might be a source of misinformation rather than accurate information on this particular pandemic. It is highly unlikely that a person who had absolutely no scientific exposure or experience or health experience would suddenly, because of COVID-19, become an expert and start churning out accurate and trustworthy information at this time alone. The desired outcome from this stage is to increase your knowledge and develop adaptive coping mechanisms, because that is what will be useful for anybody in this era of the pandemic. Now, if somebody is in the anger stage, the risk, of course, is that they may harm themselves or harm others by how they express their anger. They might go out there and lash out and expose themselves or expose others, or become, emotionally abusive, and so on and so forth. If you find yourself in this stage, it is important to talk to someone. Find somebody else that you can trust, somebody else who can listen to you non-judgmentally. Find a safe space where you can introspect, where you can think about your own anger, where you can examine the sources of this anger and start redirecting the energy to more adaptive things that you can do. The goal at this stage is to process these loss and incorporate it into memory. And the loss can be a loss of status, a loss of certainty, a loss of somebody close to you, a loss of health, whatever it is that is fueling this anger, you would want to process that loss and incorporate it into memory. Now, somebody in the stage of bargaining tends to privilege their own personal experience. So somebody would say, you know what, you guys are saying that being in crowded spaces increases the risk of COVID-19. I have been in crowded spaces and I am not yet infected. So obviously this is not working. Or I went into a crowded space yesterday, I didn't get infected. As long as I continue doing 1, 2, 3, 4, 5 things, I should be safe. So again, it might be time to get a supportive environment for yourself where you can throw these ideas at somebody else who might tell you whether this is rational or irrational. You might need a listening ear from somebody who's sympathetic as well, and start exploring more adaptive coping strategies than wishful thinking, which bargaining sometimes can turn out to be. And the goal here is to develop adaptive coping mechanisms. Somebody who has gone deeper down and is facing the reality of this COVID-19, perhaps they have personal experience with it, perhaps they have a relative who is going through it, perhaps you have taken care of so many patients with it that it is now taking you down into the path of depression. It is important to have somebody close that you can, pour out your heart to and support you as you cope, even as you start exploring life after this loss. And if the symptoms become clinically significant, in other words, interfering with your occupational functioning, with your social interactions, then it might be time to seek help from a professional. The goal from this stage is to accept the loss and plan for the future so that, your entire life is not defined by COVID-19. Your entire life is not defined by the experience you have during this pandemic. And finally, in the stage of acceptance, of course, it's a good place to find yourself in that you now understand what's going on, you understand the risks, you're taking care of yourself, you're encouraging other people to take care of themselves and supporting them. But if you reach this stage very soon, like the pandemic lands today and tomorrow you are at a place where you're like, okay, I know exactly what's going on and so on. Others might feel like you're out of touch of reality, and therefore you might be ostracized and you might find yourself being on the outer, experience, on the outer realms of experience of other people. At this point, I think it is useful for you to consolidate whatever you have learned, concretize the plans that you have, and focus on the future. What happens next? And start implementing that. The goal being that we should grow from this pandemic and find meaning for your own life and the lives of those around you, including any loss you may have suffered, incorporating that into your sense of meaning in life. So it is useful for us to keep this at the forefront of our minds, because a lot of the stigma that is being propagated by people who are at different stages of coping with the grief of this pandemic that has completely disrupted how people are living, has completely disrupted how we do relationships, has completely disrupted how we spend our time. So understanding that then would help us understand why people are still propagating stigmatizing memes, attitudes, speech, and so on and so forth. And so then we want to examine what stigma is. And stigma is considered to be discrimination against a group of people that are identifiable, or a place or a nation, or people with a certain attribute. And this stigma is often associated, obviously, with a lack of knowledge about how this COVID-19 is spreading, as well as how COVID-19 progresses when somebody has got it. And this ignorance or lack of knowledge is not only prevalent in the general population, but is also prevalent even among health workers, many of whom, under normal circumstances, they do not spend time worrying about infectious diseases and how they spread and how they affect the body and so on. But they have found themselves at a place where people expect them to know something. People expect them to say something. And so this lack of knowledge might then generate stigmatizing ideas and attitudes. A second key thing around stigma is the need to blame someone. Something has happened and people keep asking, who is to blame? We feel like it can't just have happened on its own. It can't just have emerged from nowhere and then spread so fast and affected so many people. There must be someone to blame. And so if we do not get information about where it has come from, and if the scientists we're asking keep telling us, we think this is where it has come from, but we're not so sure, we're still doing research, then in our own minds, we tend to generate an explanation that suits our purposes. And often that explanation will be less than optimum, it will be completely uninformed, and it will be blaming somebody or someone or a group of people and saying these are the reasons why all of us are suffering, and we need to treat them differently. The third thing then is about the fear about disease and death. This is something human beings faced with the risk of disease and death you'll be scared, you'll get anxious, and you'll be looking around in your environment for things to reassure you that the risk for yourself and those that you love is not as great as is being projected. The risk for you and those you love is not as imminent as is being projected. And so those fears can also fuel stigma around COVID-19. And the final component would be what would be called gossip, that spreads rumors and myths. Traditionally, a long time ago, gossip would spread by word of mouth, where somebody will tell you something in confidence, and you would go and tell it to somebody else in confidence, and it continues spreading in confidence until everybody is sharing it in confidence. But now, in this day and time, we have a larger audience than people used to have. You'd have one or two people that you could tell, but now if you post it on your social media platform, whatever it is, you're reaching thousands and thousands of people. And if they also share it with their own networks, then you're reaching millions and millions of people across the world with the things that you say. And if those things have even an iota of truth, then everything else that follows, even if it is misleading, even if it is false, will be spread widely to those networks. So it is, and the internet, social media, and so on have facilitated the spread of these rumors and myths way more than would have been the case 100 years ago, say, with the Spanish flu in the early 20th century. So then there are three key components of stigma. The main things that when they happen, it becomes a complex that we call stigma. And the first component is ignorance, lack of knowledge or lack of information about COVID-19. If you do not know anything about COVID-19, and then somebody comes and tells you something, and you trust this person, you're more likely to believe what they're saying to be true, and you're more likely to start spreading this information as though it is true. And if nobody gives you accurate information that you can then use, you tend to make up stuff. The way our brains are wired is that when you look at a space, you fill it in. If there's a pattern and there are gaps in that pattern, you fill in the gaps without even thinking about it. And this is no different from lack of knowledge in a world that requires you to have knowledge in order to make certain decisions. So when you're confronted with the need to make a decision or to say something, but then there's a gap in your knowledge, you tend to make it up, sometimes without even intending to do so. The second component is prejudice. So as a result of lack of knowledge, you develop negative attitudes and ideas about either COVID-19 itself or the people infected with COVID-19 or affected by COVID-19. And this happens inside our minds. So you start forming certain ideas that will then drive how you feel about these people or these things, and that will eventually drive your behavior. What do you think is very powerful in your mind, because it is the basis of your behavior. It forms part of the triad of the thoughts that you have that then drive the emotions that you will experience as a result of those thoughts. And those emotions are the fuel that drives your behavior. And this brings me then to the third component of stigma, which is discrimination, which is the actual overt behavior or acts that segregate or separate us from those that we consider to be in the other group, which would be either people with COVID-19, people affected by COVID-19, or people who believe differently from us about COVID-19. So those are the three main components of stigma that, if we understand how they are operating in our environment, then we would be able to design interventions that would address each of those components and therefore reduce stigma, not only against COVID-19, but against anything that people tend to stigmatize, including what happened with HIV, what happens with other kinds of human conditions that people might present with that we tend to stigmatize. Stigma operates in this cycle. And in this cycle, we begin by labeling people. We begin by labeling people with COVID-19, huyo mtu wa corona, or those corona fellows, or these Nairobians who are bringing corona to the village, and so on and so forth. So we label people, or these health workers who are bringing corona to the house, they become these corona workers, or something like that. So once we label them, then we try to create them into a single homogeneous group. And this is where we create stereotypes about them. We start, giving them attributes that lump all of them together in order for us to be able to recognize them as others. And after identifying them as others, then we divide the world and our worldview into us versus them. So we are here and they are on the other side. And remember, any group in which we belong is a good group. And any group that we do not belong to or cannot belong to is a bad group. It's less than the group in which we belong. And so once you create those stereotypes and divide the world into black and white, we are the good ones and they're the bad ones, or they're the less than human ones, then we have established the basis for stigma. And after dividing it like that, then we assign a lower social status to the other group that we are stigmatizing. They're obviously doing worse than we are. They obviously know less. And nowadays there's the word woke. They're less woke than we are. They know less than we do. They're more ignorant than we are, and so on and so forth. So they have a lower social status. And as a result of all this, then, we have established the basis to discriminate against them, to deny them certain rights, because, you know, in any case, they deserve less. They're less than we are. We deserve more. We deserve better. And so we establish a basis to discriminate against them. And so you start seeing people treating this group that is stigmatized differently, giving them less by way of resources, giving them less by way of love and affection, and treating them, you know, abysmally over a period of time. And the cycle then self-perpetuates, because when you treat people in a certain way, then you tend to see them in that same way. And sometimes they might internalize that stigma and start behaving in ways that conform to how you have labeled them. And so the label is confirmed, the stereotype is confirmed, the division is firmed up, their status is concretized, and the discrimination is justified. Now we have every right to treat them differently because of the things that we are saying. The impact of stigma in a big way is increased ignorance. So it becomes a vicious cycle where you stigmatize, and because you stigmatize, you form these ideas in your head, and those ideas become more and more concrete and more difficult to challenge. And over time, then you become comfortable in your own cocoon of ignorance because of the state of things at that time. So the result of this stigma then, in case you get infected or a loved one gets infected, you would feel like you are leaving this good group and joining the bad group. And that will give you a lot of distress. So in order to avoid the distress, many people will avoid testing. When it is offered voluntarily, people will say, I am not going to go for testing because there's a chance I might enter the other group, the group that is bad, and leave this group that I consider to be good. I do not want to be identified with it. I do not want to be labeled as a person of corona, so I will not be tested in order to eliminate completely the chance of being in that group. But as we all know, not being tested doesn't protect you from getting COVID-19. So you could still get it. You could still suffer all the consequences associated with COVID-19 despite not being tested. And that is the risk associated with stigma. Now, those with symptoms or the illness, once you get it and somebody actually confirms it, you would still want to hide in order to avoid joining that other group that you think is less than human or is deserving of discrimination. And you do not want to be discriminated against yourself. You want to remain part of this group that is good. And so you will hide your symptoms. You will behave as if you are not infected in order to avoid discrimination. And we all know the risks that then come with that. If somebody has these symptoms and they're not going to be tested, they're hiding, or they have been tested and they're found to be infected and they're still behaving as if they're not infected, the risk of other people around them contracting this illness is great. And this is being fueled by stigma. Stigma inhibits healthy and protective behaviors, as we know, and because doing these things link you to COVID-19. So you find somebody who has stigmatized the whole thing, or somebody who says it is just like a common flu. Why are we all overreacting? Somebody who thinks, we shouldn't be using so much by way of resources on this thing because it is not as important as other things that I am involved in. This person might not, wash their hands when they should, might not practice physical distancing as well as they should. They might not, sanitize, they might not use face masks, they might behave in a manner that increases their own risk of getting infected and also increases the risk to those around them. So overall, stigma undermines the social cohesion and solidarity that is required to, bring everybody together to deal with a common threat. it creates division, and therefore it leads to increased risk of spread of the virus. And this is why public health, clinicians, everybody must be alive to the risk of stigma and must be aware of some of the techniques and methods that they can use to deal with stigma. And this is what we need to do when we're dealing with stigma. In my view, if you can tease out those three components that I have just discussed, then you might have a good chance at hitting stigma out. And the first thing, as far as ignorance is concerned, obviously you deal with it by giving information that is accurate, information that is timely, information that deals with all the fears that keep coming up time after time, information that gives updates on what is now known that was not known, information that corrects things that we thought we knew, but now we know different, information that corrects the misinformation that we get. So people might have been spreading misinformation. We have to make sure that we constantly deal with this information and provide accurate, timely information to everybody who needs it. We should be able to answer questions as they arise, because when we do not answer questions, as I said earlier, people will fill in the gaps for themselves. If we do not answer those questions, if they do not trust the answers we're giving them, they will fill in the gaps for themselves. And we must be ready to admit what is not known. We must be able to say, listen, research is still continuing about that. We do not know the answer to that specific question, but we will keep searching. And when we find the answer, we will give you. So that ensures that you maintain the chain of trust, and it ensures that in future, when you have the answer to that question, you can come back and say, remember the question you asked that I didn't have an answer to. Now we know the answer, and this is how we found out, and this is what the answer is. On the second component, which is prejudice, we need to model desired behavior, because the modeling of desired behavior influences attitudes, especially by people who are influential, role models, opinion leaders, and so on. And it is my view that at this time, if people who are deeply respected by large segments of the population, if they modeled caring, humane, understanding, and helping and supporting behavior, that their followers or the people who hold them up on a pedestal will also start behaving the same way. If some of the more prominent people, opinion leaders who have been infected by COVID-19 and recovered, if they spoke more openly about it and said, this is what somebody goes through, but eventually this is how I am, and that this is not something that is out there, and this is something that can affect anyone, it helps to start shifting people's attitudes towards a more positive, caring attitude. As far as discrimination is concerned, because it is overt behavior, it ought to be, firstly, in official circles, it should be outlawed. It should be in our code of ethics. We should obviously say you can't be called a professional if you are discriminating against people on the basis of a disease that they may have. So this should be outlawed wherever possible. But otherwise, in the general population, we should do everything in our power to discourage it. And we should make it, taboo to treat people with COVID-19 or people associated with COVID-19 differently. And if anyone sees it happening in the community, it should be okay for this person to stand out and say, no, that is wrong. Don't treat this person differently because they are human just like you and I. In the process of care, and as we take care of people in a COVID-19 environment, we need to uphold a rights-based approach where everybody coming to us, we acknowledge their humanness and humanity, and acknowledge that they have certain inalienable rights, and we do everything in our power to ensure that those rights are protected and upheld, both in care and in social services. It is important for us to adopt whole community approaches. So if you're going to intervene in a neighborhood which has been hit by COVID-19 particularly hard, not going there and saying, I'm going to identify families that have been affected by COVID-19 and provide them with assistance and leave out everyone else, that would heighten the stigma. But if you go into this neighborhood and say, since this entire area has been badly affected, we are going to assist everyone to get back on their feet, no matter what their status of COVID-19 is, then that enhances the solidarity in that community, that brings people closer together, makes people more willing to help and more willing to reach out when their neighbors and others in the community are in trouble. And it is important then to assess everybody's need and deal with their needs based on the magnitude of those needs, so that everybody who has something that they need to be helped with gets help rather than, first of all, identifying them as COVID positive or COVID negative, and then providing the assistance on that basis. If we do those, if we address those three areas, those three components of stigma, then in my view, we would be making a huge dent on this pandemic. We would be bringing people closer together. We'll be, increasing solidarity, and then increasing, reducing the risk of spread and of severe consequences for this pandemic. As organizations, as governments, I think there are certain guidelines that we can follow in dealing with stigma. In care and in taking care of people with COVID-19, it is important that everybody coming to us is confident that their information will be private, their care will maintain their privacy and confidentiality, and that those who are doing contact investigation still maintain this privacy and confidentiality in order for people to be confident enough to come out and say, hey, I have a problem and I need help. If people think that the first day they show up in the hospital, their images will be plastered all over posters in town, on TV, radio, then people will be reluctant to show up. And anybody who is then treated like that will be stigmatized. It is important to quickly communicate the risk or lack of risk from different environments. So we must be up to date with our risk communication. Contact with certain products, contact with people, being in certain places. It is important for us to communicate that risk clearly and accurately and with evidence to back it up, so that if somebody comes up and says, why would you say that this is riskier than this? Then we have the evidence to back it up by way of showing how many people have been infected using this method and how many people have been infected by this other method, and therefore weigh the risk based on that. It is important for us to constantly correct negative language that can cause stigma, and we can do this by sharing accurate information about how the virus spreads. So, in the scientific, there are arguments around whether it is airborne or whether, I hope I'm still audible. So there are arguments about whether it is airborne or whether it is aerosol propelled or whether it is, droplet and so on. This is very exciting discussion in scientific circles and among lab people and among, basic scientists and so on. Very exciting, looking at the work and getting some of your hunches confirmed and so on and so forth. However, in the general public, as you communicate this, it is completely confusing. No average person walking in the streets knows the difference between aerosol, airborne, droplet, and so on. For them, it's all the same. So as we communicate this information, we must package it in a way that makes sense to a member of the public. For instance, it doesn't make a difference to a member of the public whether it is aerosolized or it is droplet and so on. It makes a difference if you told them that no matter what it is, if you maintain physical distance, if you avoid crowded places, if you use a mask, if you keep your hands clean and so on and so forth, you will be protected from this infection. So that kind of communication needs to be clear and accurate to the people out there. It is important for us to speak out against negative behaviors and statements, including those on social media. So we have to have a strategy as institutions and as organizations that looks out on what is being said on social media and that is being promoted on social media, and to periodically be speaking out against it and to be correcting that information. It is important that the images that we use in communication show diverse communities and do not reinforce stereotypes. So we shouldn't have posters and information about COVID-19 that only has a certain kind of man or a certain kind of woman or a person of a certain age only. It should be diverse enough so that people looking at this communication can identify with the message, can identify with the people, and can see that it is a broad range of humanity that is affected by this virus. And finally, it is important for us to use media channels, including news media and social media, to speak out against stereotyping groups of people who experience stigma because of COVID-19. You will remember that at the beginning, we were all calling it Chinese virus, and we were treating the Chinese people in this country very badly because we had stereotyped them and we had convinced ourselves that they are the source of this infection and that they are the ones who are spreading it. But today, of course, we know that now it is widespread community transmission, and it is pointless to keep identifying people where this virus is prevalent and then treating them differently as if we are in a different group. So it is important for us to use various media channels to speak out against these stereotypes. What you say and do matters. It is very important, especially for us in the health professions, for us who are helping people. It is important to watch our language. It is important to use people-first language, and we have learned from HIV and from mental health on how to deal with stigma. We have people living with HIV, we have people living with mental illness, people living with epilepsy, and so on and so forth. So we put people first, and then we talk about the condition that they're living with in recognition of the fact that the illness doesn't define you completely. The illness doesn't say everything about who you are. It's just a small part of who you are. So avoid associating the disease with any particular region or group. Talk about people being treated for or recovering from COVID-19 rather than labeling people as cases or victims. In fact, victims is terrible because it dehumanizes you, it disempowers you, makes you feel helpless and that you're at the mercy of others. You should avoid criminalizing language. Instead of talking about people moving around transmitting COVID-19, we should be talking about the people contracting COVID-19, people who are at risk of getting COVID-19. Because most people with COVID-19 will not go out of their way to try and get other people infected. It is important to be factual when talking about risk and to avoid apocalyptic language so that we're not talking like, you are all going to die. Because the risk is a large number of people will get infected and they will not die, and then nobody will believe anything you say after that. So we shouldn't be apocalyptic, we should be accurate, and we should be factual. We should emphasize the positive, and the positive in this case is that majority of those who get it will recover, hopefully without complications, even with the information that we're getting currently, and often without displaying symptoms. So let's find the positive around this. Let's emphasize that so that people know that there's life beyond COVID-19 and there's life around and during COVID-19. We should emphasize the effectiveness of preventive measures and the strategies like screening, testing, and treating the illness. We should emphasize the effectiveness of these measures. Because these are old medieval measures that continue to work when applied against any infectious agent that spreads the same way COVID-19 spreads. Emphasizing that these same measures have been used to control many other infectious diseases and that we expect them to be effective against this one as well is useful in dealing with stigma. As I finish, I think I would just re-emphasize that it is often just enough to try and be a good human being. That's all I would finish with. That's what I would urge all of us to try and do. And thank you very much for listening to me this afternoon.
Thank you so much, Professor Likoya Sole. And Atwoli, sorry for butchering your name. And I do agree, we should all just try to be good human beings. Thank you very much for that insightful presentation. We appreciate that you found time again to come and talk to us. We don't take it for granted. We appreciate very much. I've not seen much of experiences shared in the Q&A section. We'd asked participants to share their experience, either working in a facility where they're managing patients or treating patients with COVID-19, or whether where they stay, their surroundings, whether they've had any challenges with their neighbors at home, with their relatives, or any of the other stigma issues that they might have encountered. But thank you for that presentation. Dr. Gidwa is here with us, and we also have quite a few people from the mental health field, quite a few experts with us. I don't know if any of them would like to add something before we move on to the Q&A section. Kindly unmute yourself. We have Dr. Onyancha, Dr. Jacqueline Ocheng, Dr. Oscar Gidua. Feel free to say something or add on to the good job that Professor Likoya Sole has done. Okay, so we move to...
Dr. Onyancha?
Yes, Dr. Onyancha.
How are you?
I'm very fine. How are you?
Fine, thank you. And unfortunately, I just found the last slide of Professor. Yeah. And all I can tell about the presentation is just to be a good human being. What a powerful way of finishing. I did not see much of what you said because I was in another meeting. I was struggling to join this one, so there's even another one going on. But I just want to say that stigma is one of the things that, of course, I personally discussed in another panels with actually social scientists. And I'm glad that indeed I believe professors has addressed most of what we might have discussed. But I just want to say one thing, that yes, the last slide I saw, it was actually emphasizing on what you say, mindful of what you say and how you respond. The messages that we say speaks a lot. And I know that people want to share experiences of the stigma of COVID. My desire could have been that if there was a lot of stigma with HIV, we don't have to reinvent the wheel again, trying to actually again perpetuate a lot of stigma in this disease, because these are two diseases almost having similar with a few changes. Then it means that human beings don't learn. So we'll continually request that please don't perpetuate stigma as far as the COVID is concerned. I know many people will have experiences. I have heard of stories of even healthcare workers ourselves stigmatizing others. I don't know if I mentioned that. What I sometimes look at and say, is it like an knee-jerk reaction that we find ourselves doing what you're supposed to be, exactly opposite of what you're supposed to be doing? And so as healthcare workers, it should start with us so that we actually be able to lead by example, by not stigmatizing. Unfortunately, we find that actually, again, we are the perpetrators. Lastly, I want to say, yes, it is the way we received everything, the fear, the panic, and even the messages we passed initially. Of course, it instilled a lot of fear, and there, many at times the response stigma is about the fear of unknown. So I hope that by now we are settling down, and when we be speaking candidly, like such forums now, then we'll be able to decrease the stigma, and of course, finally, to be able to eliminate it. I wish I had seen the professor's presentation, then it could give me a chance. I don't want to say because I might be repeating. Over to you, and thank you so much for organizing such forums where we can be able to share experiences.
Thank you, Dr. Onyancha. Thank you for your comments. Professor Atwoli.
Yes.
Yes, now my question is, before we go to the Q&A section, my question is, in the stages of grief, you started with that and you said that's how it relates to stigma. Where do you think we are as a country, and especially the health fraternity, the medical fraternity? We're seeing an increase in the numbers of healthcare workers who are getting diagnosed with COVID-19. We're not going to call them cases or victims. So are we accepting them as colleagues? Are we having challenges also adapting to that? Where are we from March, compared to March up to now? It's almost 4 months down the line.
I think navigating these stages of grief is a hugely personal experience. So one hopes that as many of us as possible are able to navigate through to get to the stage of acceptance and eventually to get to a stage of growth and start looking into the future and contributing to building that future so as to reduce our own anxiety. But there's a significant proportion of health workers who are still in various stages. There are many who might still be in denial until it has hit us now, when we are starting to see our colleagues getting seriously affected. We are starting to see deaths among our colleagues, and this is hitting many health workers hard. So as people get out of that stage of denial, you'll see a lot of anger, a lot of people getting despondent, a lot of people starting to, lash out and say, the system is not doing enough to support us, and so on and so forth. So we are seeing all those stages among health workers. There are some who have taken it upon themselves to understand what's going on. There are some who have reached a stage of acceptance and now are helping their colleagues to deal with uncertainty and so on and so forth. So I think there are health workers at all stages. One hopes that we are able to navigate quickly enough that we reach a place where we are able to help others and to help each other.
Thank you for that. And yes, it's true. I think we're all at different levels, but I think once we started hearing of the demise of our colleagues, it hit home very hard for most of the healthcare workers. And probably now we're starting to take our safety and also the patient safety a bit more seriously. From Anthony Masharia is asking, are we, the healthcare providers, our own enemies? And saying, for instance, those spreading messages are colleagues at work or in the same field. Also from John Mwangi is expressing the same sentiments. He's saying, how can we overcome professional stigmatization by senior colleagues purporting that the roles we play to be of little, if not of significance? So how, is there anything like professional stigmatization? First, let's start with that. And how do we manage that?
Yeah. So those of us in mental health will tell you that this is not something new. In fact, any psychiatrist on this webinar today, if you ask them for their experience, they will tell you that when they told their colleagues from medical school that they're going to do psychiatry, they were asked an interesting set of questions. There are people who ask them, why? Why would you go and do psychiatry? You're so clever, and so on and so forth. So that is part of the professional stigmatization among ourselves. We find ways of stigmatizing each other based on the roles we play in patient care or based on where we find ourselves in the hierarchy of medicine. And so it is not strange that among professionals such as ourselves, there are already stigmatizing attitudes in regard to other things. So now when it comes to COVID-19 and people are at different stages of dealing with the grief of loss and so on, then you will understand that among us, there are those who will be ignorant, there are those who will have prejudicial attitudes, and there are those who will practice discriminatory behaviors based exactly on the same dynamic as stigma in the general population. You know, being a health worker doesn't mean you're an expert in everything to do with health. There are things that we have to learn. It doesn't mean that your attitudes are always up to scratch. There are things that we have to learn from models and so on and so forth. It doesn't mean that everything you do is up to scratch. Sometimes you have to be corrected and so on and so forth. So these attitudes are there. And some of the things we can do in the health environment is organizing forums such as this one, where health workers are encouraged to come together, to share experiences, to share knowledge, and to discuss some of the more problematic attitudes, some of the more problematic behaviors that we're seeing among our colleagues. That way, you are able to pull many more colleagues together. We're able to start getting to the same page as far as information on COVID-19 is concerned, as far as how we should treat people with COVID-19 is concerned. We start getting to the same page and we start moving forward together as one team that is dealing with a problem that is out there that we're all trying to control. So that is, I think, the only way that I can tell you that would help us to deal with stigma among ourselves as we handle this pandemic at this time.
Thank you. Thank you so much for that, Professor Lukoye. And there's a comment from Moses Mwenda, and he's saying stigma is real, especially among healthcare workers. Healthcare workers themselves are even worse, and they're avoiding psychological services provided by the teams. So he's asking us to explore strategies to reach the healthcare workers to therapy. Now that brings me to the call center that was recently opened. It's a resourceful center for healthcare workers to seek psychosocial support help. How has the uptake been? Are we reaching out for help as healthcare workers? Because that's part of the ways you brought out dealing with stigma, that we have to model the desired behavior. We have to remove the labeling and the stereotypes and the discrimination. So are we speaking out about the facilities we are working in, the way we are feeling? Are we actively seeking that service as healthcare workers?
So that's a good question, and it's a question that should apply to everyone on this platform at this time, because we have circulated the information on the helpline for health professionals. And I believe that, Rhoda, you can also circulate that after this to everybody who registered on this webinar, so that when they need, they just make a call, and there will be somebody on the other end who will pick the call, listen, and provide support, and perhaps link someone to care in case somebody needs to be linked to care. That service is now available, supported through a partnership of all the professional associations, KMA, the clinical psychologists, clinical officers, nurses, they've come together to support this resource center, whose funding has come from the COVID-19 response team that has raised some funds, and Equity Foundation has contributed to it. All health workers should use it. By last week, I think the utility hadn't picked up as much. A few people had called in and gotten support. I'm hopeful that this week we will see an uptick in the service, in people taking up this service. And we're using it as a learning platform as well. As people bring up issues, we look at them and see some of those issues that are systemic. How can we then influence the institutions and organizations to start changing those things that are causing grief to health workers, even as they deal with COVID-19? So keep calling, keep bringing whatever problems are causing you distress. You will be supported, and this will be put together, and we will use them to try and influence the system so as to improve the work environment for all health workers.
Thank you, Prof, for that. And I would want to reiterate what the professor said. It's true, please use this service. It is a service specifically created for the healthcare worker. For so long, we've not had those services within our reach, but now it is there. Feel free to call in from whichever county you're in. There'll be somebody to assist you and to listen to your queries. And who knows, probably some of the problems that you're facing at the county level or at facility level, whether private or public, might be able to reach a listening ear. So feel free to call in, and I believe it's anonymous and confidential. We will share the contacts of that KMA facility with you very soon. There's a comment from Giorgio Witty, and he's saying, thanks to Professor Lukoyatoli for this insightful session. I was stigmatized in the early 90s while handling HIV clients and never knew how to go about it. But I'm grateful for this session as it gives insight on how one can bounce back even from being stigmatized. How can somebody manage or handle or bounce back? Because there's also a similar question from Timothy Mushiri. And he's asking, what is the psychological intervention of the already stigmatized?
So that's a very important thing that all of us need to know. Somebody who has experienced stigma, when they come to us as health workers in general, as colleagues, one of the things we need to do is to validate their experience, listen to what they have gone through, validate it, and appreciate that it is something that is real, it is something that is happening out there. The next thing is to provide them with an opportunity to speak about how they felt about what has happened to them and how that is affecting how they're functioning, how that is affecting their thought processes, how that is affecting their morale, providing them with an opportunity to discuss that in a non-judgmental environment. And then the next thing would be looking at practical ways of helping them to deal with the aftermath of this stigmatization as an individual. So if it has affected them so deeply that it is causing social or occupational dysfunction, getting professional support for them so that they can get back to their usual level of functioning. If it is something that is just causing distress, but they're still able to function while in a bit of distress, providing a sense of solidarity as colleagues is important. Giving them a sense that what you're doing is still important, even though there are people out there who think that what you're doing is not useful, but we as your colleagues, we who value you and whose opinion you value, think that what you're doing is important, that it is contributing to the wider effort, and it is something that is appreciated now and will be appreciated in future. So providing an environment where people can express themselves in that manner can help to rebuild their solidarity with their peers and their colleagues, and help them to come out feeling better and stronger and knowing that the experience of stigma that they have had is not something that should affect how they continue to function. So this call line would be a beginning, but still, even where we are working, in our work environments, I am encouraging that we create forums as health workers where we share regularly our experiences with the treatment of COVID-19 and with our colleagues helping us to treat COVID-19. In those forums, we can share experiences that are stigmatizing and share strategies of dealing with that stigmatizing person or those stigmatizing environments. And when you share these ideas together, even if there was one individual in the group who still had the propensity to stigmatize others, that person will be positively influenced by seeing that a large number of his or her peers are on the same page as far as stigma is concerned. So creating these forums in workplaces, in institutions, in associations is important to help somebody to feel like they're part of a larger team, they're part of a greater service to humanity, and therefore the people who are stigmatizing them are in the minority, and their opinion might not count as much as that of their peers who are working with them.
Santi, thank you. And Professor, I know you said one of the ways of dealing stigma is to handle the triad. And the one about ignorance was to give information. But I'm seeing a very interesting question from people asking about whether the figures that are announced daily contribute to stigma. This is from Kennedy Masika and also from Grace Wairo. They are concerned that the daily announcements that are done by the Ministry of Health might be contributing to stigma. Okay. And Grace is specifically asking, why can't we just report the active people, the people who are on actual treatment? Because we keep on reporting, like now we're reporting more than 10,000, yet 3,000 have recovered and another more than 190 have died. So is that contributing to stigma? And will it reduce stigma if we stop reporting?
So here's the thing. And I've given this example before. There might be somebody who lives in a house, and in that house, the sun always rises from the east and hits his bedroom window, and makes him feel very uncomfortable early in the morning. And he gets so distressed by this, and starts wishing that something needs to change. But as long as this person sits there wishing that the sun doesn't rise from the east and that it starts rising from the west so that he's comfortable, he will always be uncomfortable. The only way to change it is to move or to find another place where the sun doesn't hit him as it rises from the east. In other words, focusing on the things that we can individually deal with and individually change helps to reduce our anxiety and helps us to grow from adversity. And so what is government doing? Government is announcing numbers of people who are infected. Government is announcing numbers of people who have died. Government is announcing numbers of those who have recovered, and so on and so forth. And government is giving a whole lot of other information as well at the same time. We choose what we focus on. We choose what we think we need to pursue and track and keep going forward. What I have told people is that at some level, if you're not actively involved in dealing with those numbers, it might not be useful for you to track them. It might be more useful for you to get a periodic update every once in a while, and you choose when to get that update so that it doesn't look like you're being bombarded with information. And for the rest of the day, you do other things that are important to you. You do other things that make you feel like you're contributing to humanity, you're contributing to your patients, you're contributing to your colleagues. And it's a personal decision to decide, what do I focus on and why do I not focus on? I would say that if every day you spend every day saying, I will not focus on the numbers, I will not focus on the numbers, you will only focus on the numbers. But if you do more positive things and say, I'm going to spend time with my family, I'm going to focus more on this aspect of my work that is professionally fulfilling, I'm going to write a manuscript, I'm going to do this, you'll find that then you have less time to focus on this distressing information that's coming out as numbers. I personally think that a responsible government during a pandemic has the responsibility to give as much accurate information as possible so that everybody listening can make responsible decisions that are informed to protect themselves and to protect those around them. So we take the government as the sun rising from the east. We take the statistics that the government is releasing as the rays of the sun rising from the east. We decide how they are going to affect us. We decide whether we are going to focus on them or whether we are going to focus on other things that are more important to us. So the fact that government is giving information doesn't fuel stigma. It is what we do with that information. It is how we respond to that information that then has the potential to fuel stigma.
Thank you. Thank you so much for that elaborate explanation. It is true. It's the way we perceive that information, how we use it, what we think about it, and what we do with it. As you said, what you say and do matters. So also the way we think about that information that is given by the government every day really matters. And there's a very interesting comment from Musila Mutala saying, thanks, Professor Tolia Lukoe. Perception is also genetic. Just borrow from Ishiara test's findings. I have observed that positions taken by different people since the beginning of the pandemic rarely change. In fact, each group of thinking tends to raise the quality of their argument in justifying a position. A real complex.
What did he say is genetic? I missed that.
He said perception is genetic.
Okay. Well, we operate on the principle that everybody has a capacity to change their mind. We operate on the principle that everybody has a capacity to learn. And learning changes, what you knew is changed by your subsequent experience and subsequent knowledge and subsequent interaction with other people. So everybody retains the capacity to learn, and therefore we do not give up on anyone. If somebody comes up with a perception that sounds strange, we make attempts to correct it so that this person, because the perception that you have influences whether your subsequent actions are going to be adaptive or maladaptive. If you can't see, if you have problems with sight, and somebody puts you on the road and tells you cross the road, and without any assistance, you run the risk of being knocked down by a car. And therefore, our responsibility is to give you the tools to enable you to manipulate the environment so that you remain safe and you remain functional. And that is adaptive. But continuing to operate with misperception is maladaptive and is potentially harmful to you and potentially harmful to other people. So I do not believe that people are fixed in how they see things, that people are fixed in how they think, that people are fixed in the amount of knowledge they have. I believe everybody has the capacity to learn, and it is only up to us to discover where we start in order to help them to learn and reach a place where their behavior becomes adaptive.
Thank you. My next question is about the handling of bodies, the burial that we've observed. We've observed quite a few. And Peterson, Washira, Elizabeth, Irungu, and there's one more person who expressed their concerns about the way we've been handling the dead bodies, the patients we've lost. So are we causing more stigma? And how best can we handle the burial process?
Yeah. So I think not being at the forefront of understanding, because none of us at the moment fully understands, or even at the beginning when we started getting deaths, nobody fully understood the degree of infectiousness of, even people who have died. Nobody could pinpoint and tell you, at this point after somebody has died, they stop being infectious. And secondly, the perception of the severity of the pandemic and the infection and the problems it can cause, that influences public health decisions about how do we handle bodies of people who have died with COVID-19. So those protocols will be developed based on that information and based on that knowledge. It is our responsibility then, when we are interacting with members of the public, to firstly try and explain the basis for how the body is being treated. So people need to understand why we are treating the body like that, perhaps because we do not know how infectious it remains even after somebody has died. So that should be something that should be clear to everyone. Why are we putting it in this material and so on and so forth? But more importantly, we must make every attempt to preserve people's mourning rituals as much as possible. We must make every attempt to ensure that people do the things they usually do when they bury people within safe limits, of course. So the balance needs to be struck between the need to, as quickly as possible, get this body into a safe place where other people are not at risk, but at the same time, to have the relatives and the family do the things that they need to do in order to find closure after a relative has died. And I'm seeing that a fine balance is now being struck, where the body is handled the way it is handled, but then the family is given an opportunity to have a funeral service, the family is given an opportunity to mourn, and the family is given an opportunity to bury their relative under relatively good circumstances compared to the beginning, where everybody was rushing to bury people at night, which was really inhumane and didn't do anything to reduce risk of spread or anything like that. So one thing that we must do is that we must trust the people to have their own best interests at heart. And that if we give them sufficient information on how they can protect themselves, they will give us ideas about how to better do our job. If they know what our objective is, and we ask them, how do we achieve this objective best in your environment? They will be the best teachers, and they will tell us, oh, you want to bury this person quickly because of the risk of infection. We have a situation like that in our culture, and this is how we handle things like that, and it will be culturally acceptable. The people can teach us. So we need to trust people a lot more, allow people to educate us a lot more, as long as they understand the objectives we're trying to achieve.
Thank you. Now, when you're talking about dealing with stigma, you brought out the role I play as an individual and the role the government or the organization plays. And you brought it out very clearly. For the individual, I'm supposed to handle the trial, that's the ignorance, the prejudice, and the discrimination, and also be very clear on what I say and what I do. For the organization or the government officials, it's to maintain the privacy and confidentiality, communicate the risk or lack of risk, correct the negative language, speak against negative behavior. And you also talked about using media channels well to reduce stigma. Now, from Kennedy Ambonia and there's somebody else who was seen who's asking about whether there are any guidelines that you've developed, either you or a team you might be aware of. There are any guidelines to prevent and address social stigma associated with COVID-19. So other than the knowledge that you've given us, is there a protocol somewhere which somebody can access and know how to address that social stigma?
So there's no standalone protocol for dealing with stigma, but there are a series of guidelines for health workers and other responders during this COVID-19 in mental health. There is a guide on mental health and psychosocial support that's available on the Ministry of Health website that has a section on how to handle stigma. There is publicity material also that deals with stigma. There's a whole wealth of material on the Ministry of Health website that have the tag mental health that would have a component that advises on how to handle stigma. And a lot of what I have said today is included in those documents. So if somebody just accesses the mental health materials from the Ministry of Health website, the COVID-19 mental health materials on the Ministry of Health website, they will find a wealth of information on how to deal with stigma, among other things that might arise during this pandemic and that affect the mental health of our people.
Thank you. And speaking of guidelines and protocols, there's an interesting question about whether the government protocols and directives have fueled stigma and what can we do about it?
Yeah. So it is true that I think observing how we responded to this pandemic from the beginning, a lot of mistakes were made in communication. So obviously there were experts involved in crafting the response, in doing modeling, in getting as much information as possible in order to inform the response to reduce the risk of infection, reduce the risk of mortality, and to track the pandemic. So that was purely, professional, scientific, and so on. But how we communicated this to the public, in my view, there was a bit of a problem. We presented this in language that was easy to deny. If somebody comes and says, if you play around and all of you get infected, you will die. And then I saw a lot of people starting to ask in the first days in March and April, why are people not dying? We're not seeing people dropping in the streets. People converted this, you will die, into everybody will die, and into people dropping dead like flies, and into people dying on the streets. I don't know how that, that evolution happened over time. It's the same way it happens in that game that children play of broken telephone, where you tell somebody something and somebody adds something on it as they go forward and so on. So how we communicated that, how we failed to correct ourselves going forward and continuing, and allowed these stories and apocalyptic visions to spread, might have then started to contribute to stigma. If we had been factual, if we had constantly corrected course when we got new information, perhaps people might have responded differently. The second thing that we didn't do so well in the beginning was that we depended a lot on coercion in order to get people to cooperate with the prevention measures, instead of depending on a model that brings cooperation and solidarity and brings people together to design solutions that achieve the same objective that we want to achieve. We elected to use police force, we elected to use restrictive legislation and so on, instead of using persuasion. So I think we lost an opportunity there. If we had persuaded people to work with us to deal with this pandemic from the beginning, we would have less stigma, because people would be handling it in their communities in a manner that they understand better than those of us sitting somewhere and trying to imagine how people deal with this. And finally, I think if we had availed ourselves of the services of other social scientists, including behavioral scientists, including mental health people like ourselves, but also including anthropologists and perhaps sociologists, it might have been a more holistic response that anticipated the stigma, that anticipated people's reactions up to this day, and perhaps designed a method to deal with it as we handle the pandemic on the side. It is not too late. We can still do the course correction as we go along. I see the ministry making attempts to course correct, and that is a good thing. You know, changing from talking about social distancing, which has ominous implications, to physical distancing, which is more realistic. Stopping, you know, giving out elitist suggestions on how people should protect themselves, to being more practical, and enlisting people as, you know, one community dealing with a problem out there, rather than being we, the responders, and you, the people, we are telling you what you need to do. So we need to do this more often. We need to listen more to the people and communities. We need to incorporate their suggestions into our agendas. But importantly, we need to be clear about our objectives and communicate clearly about our objectives and solicit support from the community on how to achieve those objectives, rather than just communicating the path towards the objective. And people do not know why you're doing the things you're doing, and they feel coerced to do it. In Nairobi today, you will meet people wearing what we call chin support. And they're wearing chin support because the law has said, if you don't have a mask on your face, you will be punished. And so they're putting on those masks because they don't want to be punished. But if you had explained to them the rationale behind the decision that as many people as possible should wear masks, and protecting other people and protecting themselves in the spirit, African spirit of Ubuntu or Utu, perhaps a lot more of the population would have cooperated and would have come up with innovative suggestions on how to protect others in the environment. So we need to continue learning, we need to continue improving our communication to the people, but we need to listen more to the people out there, to the communities, and they have wisdom that can help us to design better interventions.
Thank you for that, Professor Lukoye. And still on the government directives, there's an interesting question that has just come in from George Otieno, and is speaking specifically about the 60-year-olds and under 13s who've been asked to stay away from church and attending political forums. And is asking, is it not promoting stigma and discrimination? But my question now goes to, where do we draw the line between protecting the individual, protecting the public, and stigma? Because some of these measures that have been put in place are actually for our own protective measures. But we've decided to interpret, perceive them in a different way as a restriction that the government has put in place. And that's why we're seeing the change support, as you're saying. We are not taking the messaging or the risks a bit too seriously, as we have been explained to. So how do we differentiate between protecting the public, which is the government's main role, public health role, and calling out stigma and discrimination, because we'll have a lot of that as the days continue.
Yeah. So again, it's a matter of, in my view, it's still a matter of communication. If I went to the village and I told the people in the village that there's this disease, that when it affects somebody who is 60 years and above, the chances of it killing this person is extremely high. And if I went there and told them that when it affects somebody who is young, while the chances of killing them might be low, anyway, firstly, the loss of a child under that age is extremely painful to the parents, but more importantly, that they might remain infectious for long periods of time and that other people around them might get infected. And then you ask them, I am intending to reopen this particular activity. How do you think we should deal with these demographics? If that is the reasoning behind it, you would get, people would tell you themselves that no, there are ways in which we will prevent these young children and these older people from participating in this activity without making them feel like they're excluded or stigmatized or anyway. And sometimes they might tell you, we will get those 60-year-olds and those 13-year-olds to do the communication themselves. And they will communicate to each other in language that is appropriate to them and that makes sense to them. So I think while we come up and say this is a high-risk group and so on, then as we communicate this information, we should engage those people in that group so that they are able to communicate to each other in language that is not stigmatizing and in language that makes sense to them. But crafting a general regulation and then throwing it out in one language, throwing it out with the same voice, doesn't communicate the same way to the different demographics we're trying to communicate to. And that will definitely fuel stigma, because now if you're 60 years old, people start making memes about you. People start saying that you're the one who will die of COVID, as opposed to somebody who is 55. And yet if both of you got the illness, you might get the same degree of complications, you might get the same severity of illness, and so on and so forth. So our communication strategy needs to evolve so that we are able to speak to the different demographics in our population.
Thank you. Thank you for that, Professor Atwoli. And before I let the participants who've raised their hand comment, could we get a quick comment from Dr. Gidua?
Mm-hmm.
And then we can allow the participants who've raised their hands to unmute themselves and ask your question. Dr. Gidua. Hello, Dr. Gidua.
Yes, I'm here. Thank you so much. First of all, thank you so much, Prof. Lukoye. That was a really informative session. And I think that, the question about stigma for us is now much more clearer. I just had two quick comments to make. Sorry for the noise you can hear in the background. I'm in the frontiers of this country, somewhere in the north. And but I said I wouldn't want to miss this session. It's that important also. So the first thing that I want to make was the first observation, I think, is starting from where Professor has left off when it comes to the question of communication. And I think that we still have a lot to do when it comes to communication. We have communication on various levels. Of course, a lot has been done so far when you hear the top ministry officials speaking about the pandemic and the numbers. You can see the language is changing. Of course, there are slip-ups from time to time. But what I want to add on to what Professor said is about the segmentation of society. Remembering that the messenger is as important as the message. I think we said that some time back, that the messenger is as important as the message, because we want to hear from someone who looks like us. Kenyans want to hear from someone. And I think it's only until recently, when the names of people who've probably passed away from COVID, that the question of the seriousness of COVID-19 is hitting home for some people. So I think that's the first thing. The second one is to respond to one of the participants who was talking about how do you treat stigma, that is someone who's been stigmatized. And I know that Professor dealt with it pretty extensively. I just want to remind us that, remember that as a healthcare worker, you already have a long history of stress, and especially because of working in a high impact profession. In as much as you're trained to work in that system, I don't think that anybody is trained necessarily at the beginning in how to maintain and sustain high levels of stress for a long time. For many of you, maybe for a lot of many years, and others for decades. So the one thing that I would like to say, it's a time for solidarity, all the healthcare workers. It's also time for solidarity and time to be supported, because it's a very unprecedented time. And I think that there are many things that someone can do. Of course, we've spoken about what you can do individually, what we can do at policy level and institutional level, but I also wanted to extend the hand of help again and remind us that there are groups that we've organized, especially with this platform at KNH, every Tuesday and Thursday at 10 a.m. for people to just join in and actually share what their experiences are. We have a lot of psychological first aid sessions running already, and we're in the process of now segmenting people into different departments as well as professionals to be able to work together, because the issues that a farm tech face might be different from what a nurse might face, might also be different from what a medical or a clinical officer might face as well. So I think for me, that's a parting shot on my end. But to say that thank you so much, Kenny, the work that you're doing is so great, it's unprecedented. And Professor Tolly, the way you drove the subject home, really, really great. Thank you so much for the opportunity, Dr. Kalandu. Thank you.
Thank you, Dr. Gidua. It's always good to hear from you, and enjoy the northern frontier of Kenya. George Kiema, Nelly Omoke, Jacqueline Makoha, Thomas Ogondo, Duncan Jigu, Teresia Kinyaru. Kindly unmute yourself and ask your question or share a comment.
Thank you, Professor Lukoe, for a good presentation. I had a question about the way the tracing teams usually use sirens, and just the fact that they wear hazmat suits. I feel that could actually be contributing to our difficulty in tracing contacts, because if, for example, I'm confirmed to be COVID positive, I don't want my neighbors to get that scaring experience of having sirens coming to their compounds, and just that approach. Is there an easier way and a less scaring way that tracing can be done? Over.
Yeah, thank you very much for raising that. I think I hope in my mind that that was a phase in this intervention that we shouldn't be seeing too much of going forward, unless it is they're dealing with an emergency and they're using the sirens to clear the way and somebody's in dire straits, just like we do with ambulances. That would make sense in that context. But if it is just going to trace somebody and get them to be tested and so on, I would hope that now, at this phase in the pandemic, that is not happening. And if it is, then we have to reevaluate so that we do it a bit differently. Sirens and speed and so on should be applied when there is an emergency. And those of us in the health sector know what a health emergency is. And going to test someone who is at home for COVID, especially somebody you have communicated with on phone, is not an emergency in that sense. Unless this is somebody who is having breathing difficulties, is collapsing, then it becomes an emergency in that way rather than as far as COVID-19 is concerned. So I agree with you that as we start reaching out to people to inform them that they have been exposed and that we need to test them, or that we have tested them and we have found that they are positive, I would hope that we are no longer sending sirens and huge teams to their houses to go and scare the entire neighborhood. I'm sure we have evolved different ways of doing this. And with the onset of this home isolation, I would expect that a lot of the visits to homes and so on would be to just assess whether the home environment is suitable or not, and to explore what can be done to support somebody while they're isolating at home. So I fully agree that if I'm sitting in the neighborhood and I look at my neighbor's house and there are vehicles rushing in with sirens and so on, it inevitably creates a certain attitude, a certain perception about this person that is very difficult to shake off, even after this person has gone through and has recovered and is well. It is difficult to shake off the experience of seeing how he was picked up and so on and so forth. So I'd expect that changes in order to help us reduce stigma.
Thank you for that. George, Melly, Jacqueline, Thomas, Duncan. If you have a comment or a question, unmute yourself and ask. Yes, Jacqueline.
I think my question has been answered. I wanted to ask about the siren issues.
Okay.
Thank you.
Okay. Thomas?
Hello, my name is Thomas.
Yes,
Thank you, Professor, for the wonderful presentation that you made for us. I'm raising a question in reference to home-based care, as in home-based care where clients are having mild symptoms and they are taking full care of themselves, washing their utensils, they are doing most of the activities for themselves. And in our society, we know very well that, of course, if the breadwinner is affected, you'll expect the activities like the washing of the clothes, utensils to be done by the contacts of who are the caregivers. I don't know how the government is going to help us so that it doesn't become another source of gender-based violence and stigma. Thank you.
Yeah, thank you. That's a tough one, and I would not purport to have any answer to that. Usually for such things, if I was the one advising somebody who is doing home-based care, and this person asked me about how they would take care of their utensils and so on, what I would communicate is that anything that they have touched and they give somebody else to touch is potentially infectious, and there are ways of disinfecting those things. And then I would be asking from this person that, given the scenario I have given you and the information you have, what do you think works in your own setup to ensure that the people who are coming into contact with these things do not get infected? And you will be surprised with the answers. There's somebody who told me yesterday that what they're doing now is that they make food for this person who is in the room, and they put the food there, and then they go away. This person comes and collects it, locks themselves in the room, eats. When they're done, they put that plate outside, and this person who's coming to collect it, they spray it with the disinfectant before anybody touches it, and then they go and soak it in soap and water and so on before they do anything with it. And people have all those sorts of solutions that work for them. So somebody else might be living in a house where the bedroom is completely self-contained and they can do all those things for themselves, and that works for them. So it is about finding contextually relevant ways of ensuring that the risk of infection is not increased, and recruiting these people in the community to advise you on how to achieve that objective of reducing the risk of infection without putting other people at risk. So I would really, in such a situation, listen a lot more to the person that we're advising on home-based care, but first by giving them the objectives that we're trying to achieve, and then finding out from them how we can achieve those objectives in their own environment.
Thank you, Professor Atweli. And my last question to you, it's about self-stigma, and this is from Dorcas Karanja. She's asking, she's actually saying, I think I have a low percentage of self-stigma as I found myself not disclosing that I'm a healthcare worker. There's also one from Yusuf Mohammed, a comment. My experience in COVID-19, we are called the Corona team by our colleagues, labeling us our first name and second name being Corona. For example, Yusuf Corona. So let's talk about self-stigma. How do we handle that?
Self-stigma is a product of stigma. So when we stigmatize people, there are certain people whom then they will have this stereotype that you have applied to them. And they will become aware of that stereotype. And over time, they start confirming that stereotype for themselves. And after confirming that stereotype for themselves, they, at some level, accept it. And once they accept it, they start behaving in conformity with that stereotype. And so they have internalized the stigma that people have directed at them. They have internalized it, and they're now living that stigma as a reality for themselves. And this will then affect your self-perception. It will affect your self-esteem. It will make you do things that you wouldn't otherwise have done because you're now scared of doing those things as a result of this self-stigma. So it is real. And health workers handling patients with COVID-19, the risk of self-stigma is high. And so to ameliorate that risk, it is important to ensure that you are not a lone ranger, you're not operating in your own bubble alone, but that you have this network of colleagues, that you are engaged in the same work, that you are facing the same realities, and that you share these experiences regularly with, in order to remove it from you and put it back into the community that has been stigmatized, and then to deal with it as a group rather than as an individual. I find that it is very liberating sitting with a group of peers and they start talking about the same experiences they're going through, and you identify that this is exactly what I'm going through. And then somebody comes up with a strategy of how they're handling it, and it looks like it is something that you can do to support yourself as well. So I think those forums, like what Oscar has said, where people are able to log in and just share experiences, should share experiences, including experiences of stigma and how they have dealt with it and how it is affecting them, is very helpful in reducing the risk of self-stigma. If you are just operating alone and you are treated a certain way, and the people treating you that way seem to start having a power over you, and you confirm this stereotype and accept it and start living like that, it becomes part of you. And the tragedy is that the people observing you then will only see that stereotype, and it will confirm it in their own minds, and it forms that cycle that that ensures that you continue being treated in a bad way. So, but if you have a group, it is unlikely that the entire group will be experiencing self-stigma. Others will provide support for you. Others will provide ideas on how to deal with it when you're going through it.
Thank you. Thank you so much, Professor Lukoy, for that. And thank you for finding time. And before I let you go, there's a comment from Peter Mwangi. Peter Mwangi is introducing himself as the National Chair of the Kenya National Union of Pharmaceutical Technologists. And his concern is about the initiative towards helping healthcare workers. So maybe you can repeat again about the good work you're doing in KMA at the call center so that Peter can know that the pharmaceutical technologists are also included in that initiative.
Yeah. So what has happened is that KMA convened very many professional associations, and it is not only KMA now, it brings together clinical psychologists associations, nursing, National Nursing Association of Kenya. In fact, National Nursing Association of Kenya is hosting this call center. Clinical Officers Association are part of it. Pharmaceutical Society of Kenya, everybody is welcome. So this initiative, when we started thinking about it, we had only the knowledge of the people we work with. And so we approached various people to support it. But then these people were clever enough to say, we will support it, but let it be open to all health workers. And that was a good idea because then it enabled us to create this team that worked together to develop the proposal, create the resources, and have people who are sitting in that call center every day to receive calls from any health worker. So the information, there are posters that are going around. I hope there's a contact number that will be circulated that any health worker experiencing any difficulty during this time of COVID-19 can call that number, say what they're going through, discuss it with a counselor on the other end, and they will be supported. When you call in, you will get somebody who will quickly triage your concern by listening to you and figuring out what support you need, and then they will link you to the kind of assistance that you require while you're still online. So whether you're a pharmaceutical technologist, whether you are a clinical officer, a doctor, nurse, a nutritionist, anybody who is a health worker and you're going through difficulties during this time of COVID-19, you can call that line and you'll be linked to care, you'll be provided with support, and even if you need offline support, they have SOPs that help guide them to show you what kind of support is available in your environment. So no health worker is left out. Everybody who works in a healthcare environment and is having these challenges during COVID-19 can use that hotline. It is toll-free, you will not be charged, and it is not discriminatory. If you call in, nobody will ask you, hey, when unafanya kazi wapi, who are you, and so on. People will listen to your challenge. They might take a bit of information in order to be able to pass on whatever needs to be passed on to institutions to improve the working environment, whatever needs to be passed on to government to change their policy, and whatever needs to be passed on to the professional associations so that they can better support their members will be passed on. So do not hesitate to use it. If your association is not listed among the associations partnering, it is not because it was actively excluded. It is just because at the time that things were being put together, those that have been listed are the ones that people could think of quickly. But you can get in touch with the KMA Secretariat. If you have any special needs as an association, you will be included and you will be supported.
Thank you. Thank you, Professor Lukoy, for clarifying that. And I hope everyone has heard and you'll be able to get in touch, get help where you feel there's need for help. Don't suffer in silence. Please make use of that service. It is there for us as healthcare workers. It is free of charge. You call in and you get the assistance. And if there's need to refer you for more specialized treatment, I'm sure they will direct you. So please make good use of that service. Don't let it go to waste. Make good use of it. Thank you, Professor Lukoy, again, once more. We appreciate you and we thank you for always finding time to come and take us through some of the interesting scenarios that we see and the topics that you've been taking us through. Somebody was suggesting that you should be on national TV, and I'd like to tell that person yesterday, Professor Lukoy was on national TV. with Professor Mwanzala, and they did a good job. So always watch out for primetime news. That's where you'll most likely find them. To the rest of the participants, thank you so much for finding time to attend this session. I hope you've learned something about how you can reduce stigma as an individual. And also, if you're in charge of an organization or if you're working in an organization, there's a role that you have to play. If it's a ministry level, there's a role that the government has to play. So let's be the change agents in this trying times. In these times where nobody knows what is happening, there are all manners of information, some real, some not real. Let's be the voice of change, the voice of reason as healthcare workers. It is the least we can do, and it is our call of duty. So please, let's reduce stigma among ourselves as colleagues, and also to the patients and to the public. For those who are asking for clarification about the PPB CPD points, yes, today is July 15th, and I'm very happy that the day is finally here. We were promised that we'll have a streamlined system by the team from PPB, so we hope to see the changes. Kindly let us know if you experience the changes. We would not know, but you is the receiving end, you'll be able to alert us whether it is working or it is not working. So please feel free to always share your feedback with us. For somebody's asking about CPD for nursing, yes, we have one of our, Rose Njoroge is trying to streamline that process with Nursing Council of Kenya. But in the meantime, if you are within Nairobi, feel free to bring your book, we will sign it. Jen Mwangi, you asked if you need to send us your email again. Not yet. We've not yet gotten any communication from PPB, whether you need to send us your email or that information again, but we will wait to see. We will communicate if there are any changes that will come about. So thank you all of you for attending this session. Tomorrow we don't have any session, but on Friday we will have the experience sharing session. Friday, 10 a.m. to 12 p.m. Please come and hear what the counties are doing, the frontline healthcare workers, what they're doing, and it's a good sharing experience. So come hear what others are doing and also what your county, because you might be in the county, but you don't know what is happening. So please come and listen to that. Have a good afternoon and God bless you. Bye.
Bye.